then the bowel wall can be eaten right through, creating a communicating fistula. So, things you should remember are Crohn's disease, the transmittal granulomatous inflammation, terminal ileum, and the formation of fistulas, typically are characterized as Crohn's disease. Also, the distribution of inflammation through the GI tract, characterized by these discontiguous segments of affected bowel with intervening skip lesions, which aren't lesions, but are actually normal sections of bowel. So we were about to examine some of these fistulas. We can see it's caused by these granulomas that are distributed throughout the entire wall. Take a look at one of these fissures and fistulas. Here's a section through a fistula, or I should say a fissure becoming a fistula. Again, you can see the lumen of the bowel right there. You can see the different sections of bowel wall architecture. We have a mucosa here, barely a mucosa. There's submucosa here, and you can see the intercircular layer of the muscularis propria here. This part of the bowel is somewhat intact. It's not normal, but at least it doesn't have a big hole through it. Over to the right here, however, you can see there's a defect in the mucosa that extends all the way down into the intercircular layer of the muscularis propria. And the walls of this defect are lined by lots of inflammation. This is in a deep ulcerating fissure that will most likely turn into some sort of communicating fistula. All right, let's take a look at the appearance of Crohn's disease macroscopically. We want to take a look at the bowel wall, see how it's affected. Macroscopically, let's take a look at a normal specimen first. This is a resected segment of terminal ileum, cecum, and descending large bowel. The specimen's been opened along its longitudinal axis, so now we're looking at the mucosal surface. So you look down at the terminal ileum here, you're actually looking at the mucosa here. And you can see it's characterized by very large folds. These are the pupae circulare. Okay? Kind of stained a kind of a green-yellow color. That's because it's bile. Okay, if that's what normal looks like, here is what Crohn's disease would look like. You're looking into the small bowel via a colonoscopy, and of course you can see the center of the lumen of the bowel here, and you can see the wall of the bowel here. You'll notice the topography of the bowel wall is characterized by these areas that seem to bulge outward, and then you've got other the areas of bowel that are kind of bulging out, surrounded by areas that seem to be fissured. Okay? This type of architecture generally is a type of topography that kind of resembles a cobblestone pathway, and so the texture is referred to as a cobblestoning texture. Cobblestone. This is typical of what you see in Crohn's disease. These areas of bowel wall that seem to protrude outward are actually areas of intact bowel wall architecture, and they're flanked on either side by these fissuring defects that could extend through the entire thickness of the bowel wall. The texture itself is referred to as a cobblestoning texture. Note that the word cobblestoning is not specific to Crohn's disease, it just refers to a texture. And it just so happens that this texture looks like a cobblestone path. Okay. All right, let's talk a little about the presentation. So as I said before, all these inflammatory bowel diseases are characterized by recurring, these remitting, relapsing patterns of diarrhea. The typical episode for Crohn's disease may last a few days to weeks. Usually there is blood in the stool. It could be in the form of red blood, but in the case of Crohn's disease, considering where the damage in the bowel occurs, which is in the terminal ileum, it's proximal enough to present as melena. Okay, generally any bleed proximal to the transverse colon will present as melena. If there's any blood, it's usually melena in the case of Crohn's disease. Okay, so workup, you would include some sort of colonoscopy, sigmoidoscopy. You are gonna see isolated segments of bowel that are affected. Intervening segments of bowel should be normal, those are called the skip lesions, and the interface between the affected and normal bowel should be pretty sharp. Most of the area that will be involved will probably be terminal ileum, but you could have other areas of bowel involved as well. A biopsy should be remarkable for granulomatous inflammation. In reality, the granulomatous inflammation will be transmural. You can't really see that in a biopsy though, because if you were actually to document transmural granulomatous inflammation on a biopsy, you would have had to punch an entire hole through the wall of the bowel. So you can't really see that in a biopsy, but you will see granulomatous inflammation. Based on what you see, you probably can extrapolate that it's transmural. The inflammation is pretty significant over the course of time. The constant damage caused by inflammation can cause significant regeneration. And you know, if you have any kind of abnormal regeneration, cells got to replicate, they got to replicate their DNA at an accelerated rate. That's going to result in mutations, and the mutations going to result ultimately in dysplasias. So people with inflammatory bowel disease tend to have an increase in risk of the development of bowel cancer. So there's a significant risk in developing bowel cancer in people with inflammatory bowel disease. Okay? Ultimately, the scarring that results from the inflammation causes significant stricturing of the bowel. I'm going to show you that really graphically in a few minutes. The condition is associated with these chronic relapsing, remitting episodes of diarrhea. When a person is having a relapse, they are going to have diarrhea constantly. However, when the condition remits because of the scarring in the bowel, usually they're constipated. The bowel has really poor motility as a result of all the scarring. So they go between basically having the runs and being constipated. Okay, any questions about Crohn's disease? Terminal ileum.
Once the fissure forms, is the fate of it will end up being a fistula, or will it regenerate and fix itself?
It doesn't have to progress to a fistula. It can.
Okay.
The bowel mucosa can regenerate, but if the fissure goes through the muscle is going to be scarred.
Okay.
Okay, anything else, Crohn's? Okay, let's talk about ulcerative colitis. UC, this is another form of inflammatory bowel disease. This is also a systemic disease. Just because we call it inflammatory bowel disease doesn't mean it can't affect other parts of the body. Again, there's significant extraintestinal effects as a result of this disease. Ulcerative colitis is so called because most of the inflammation of the bowel is isolated to the colon. Very often the rectosigmoid region. This particular condition is associated with a diffuse mononuclear inflammatory inflammation. It is not granulomatous in nature. Also, the distribution of the inflammation is not transmural. The inflammation will affect the mucosa and submucosa, but it generally does not extend into the muscularis propria. So we have a inflammatory bowel disease, generally limited to the colon. The inflammation is diffuse mononuclear, and it generally doesn't go any deeper than the submucosa. Okay, let's take a look at this. Again, we have the anatomic distribution of inflammation. It's typical over here. Most cases of ulcerative colitis involve the rectum and the sigmoid colon. About 80% of the cases are limited to this area. Any other area of the bowel that's going to be affected will result from the spreading of this inflammation proximally and continuously, possibly to involve the entire colon. When the entire colon is involved, we call it pancolitis, pan meaning ball. Notice the inflammation is always continuous. There are no skip lesions involved. That's something that's characteristic of Crohn's disease, not ulcerative colitis. The inflammation will start distally here in the rectum, and it will spread proximally and contiguously. No intervening normal bowel at all. Okay. Hey, now, take a look at a section of affected bowel. Here's a look at an area of affected bowel, and you can see we have an area of bowel here that has a luminal topography that's characterized by these peaks and these troughs. These peaks are actually areas of intact bowel wall. These troughs are actually areas of bowel that have been ulcerated right down to the muscularis propria. You take a section through the affected bowel. This is what you'll see in cross section. Then you can see the lumen here. You can see areas of bowel wall that are intact, that are flanked on either side by areas of bowel that are ulcerated right down to muscularis propria. We take a look at an intact area of bowel. Again, you can identify the mucosa, the submucosa, the muscularis propria, and there's the serosa. Now you notice that these areas of intact bowel wall, because they are flanked on either side by areas of bowel that are eroded down to the muscularis propria, these areas of normal bowel kind of look like they stick out like a polyp. They kind of look like polyps. They are not polyps. They're areas of intact bowel wall architecture. But because they look like polyps, they're called pseudopolyps. So these pseudopolyps are actually areas of intact bowel wall flanked on either side by ulcerated bowel wall. All right, let's have a look at this architecture. Let's first take a look at the gross appearance of ulcerative colitis. First, again, we'll take a look at normal bowel. This time we're going to concentrate on the large bowel. This is a resected segment of ascending colon. Again, you're looking at the mucosa, and you can see it's characterized by these large folds. Everything looks good here. Okay. Let's take a look at the appearance of the colon when it's affected by ulcerative colitis. Here's another resected segment of colon, this time affected by ulcerative colitis. Again, you're looking down at the mucosa, again, what's left of it. And the first thing you notice, probably the color. It's erythematous, it's very inflamed. It's very hyperemic from the inflammation. You look at the bowel topography, again, you'll notice there are these peaks and these troughs. These peaks are areas of bowel that are intact. These troughs here are actually areas of bowel that are eroded down to the muscularis propria. Now, again, a lot of these areas of bowel that are intact are flanked on either side by areas of bowel that are ulcerated. That makes the normal area of architecture kind of look like it sticks out, making it look like a polyp. It is not a polyp. This is what we would call a pseudopolyp. That would be an example of a pseudopolyp right there. All right, let's take a look at one of those pseudopolyps. We're going to take a section through the polyp. Take a look at that architecture. Again, we have the lumen of the bowels over here, and you can see a section through the bowel that's intact right here. Again, you can see there's the mucosa, that's the submucosa, this is the muscularis propria, intercircular, outer longitudinal, and there's the serosa right there. Now, you take a look at this section of intact bowel wall. It's flanked on either side by parts of the bowel that are eroded right down to the muscularis propria. That's classic ulcerative colitis. Eats right down to the muscularis propria, but not into the muscularis propria. And as a result of the bowel being extensively ulcerated on either side, you can see this area of intact bowel wall kind of looks like it sticks out, and it actually looks like a polyp, but of course it's not. It's just an area of intact bowel wall. And so that's why they're called pseudopolyps. Okay. Ulcerative colitis can follow, again, that chronic remitting, relapsing pattern. People will have episodes of diarrhea. Again, usually there's blood and mucus in the stool. The blood is more likely to be red in color because this is a disease that affects the distal portions of the colon, and therefore you're probably going to see some shade of red of blood in the stool along with a lot of mucus. Okay? People are going to have, again, these remitting, relapsing episodes. Sorry about that. He's going to have these remitting, relapsing episodes. And again, these episodes are going to be characterized by just a lot of diarrhea, a lot of mucus, a whole lot of blood. Now, over time, because the disease is remitting and relapsing, the bowel goes through a lot of damage, a lot of regeneration, a lot of scarring. You can see the extent of the scarring on a radiograph. Let's take a look at the extent of scarring that we see. First, let's take a look at normal bowel. This is a lower GI series. It's a series that we obtain using a barium enema. It's a good way to visualize the liminal topography of the large bowel. You can see we've got here the some of the small bowel here. This is terminal ileum. That's the ileocecal junction right there. This is the cecum. You can see the ascending bowel. We've got the hepatic flexure over here. That's the transverse colon. And you can see over here on the left, we've got the splenic flexure, and we've got the descending bowel. That's the sigmoid colon. Hidden behind here, we can see a little bit of the rectum right there. Okay, this is normal bowel. A couple of things you want to notice about the normal bowel. First of all, look at the length of that bowel. There's a lot of slack in the bowel. You know, it kind of goes up this way, kind of makes a lazy turn over here, goes up. There's a lot of slack in this bowel. A lot of additional length. There's no tension in that bowel at all. Notice the caliber of the bowel. You've got these kind of fluctuating diameter bowel. This is, of course, the rostrum. A lot of the bowel here is a wide patency, other areas a little smaller patency, but this is all normal for the large bowel. Take a look at the lumen. The luminal topography is smooth as you would see it on a radiograph. Everything looks normal there. Ulcerative colitis, the chronic remitting, relapsing episodes of inflammation will cause a lot of damage to the bowel. Now, some of that's going to regenerate. The mucosa, for the most part, will regenerate. Sometimes the regeneration is abnormal, but it'll regenerate. But the rest of the bowel, things like the muscularis propria that might be damaged, it's not going to regenerate. It's going to scar. And scar tissue tends to contract over time. And so if this is what normal bowel looks like, this is what the bowel of someone with ulcerative colitis looks like after a few years of having the disease. So again, this is a lower GI series. You can see the rectum here, sigmoid colon. There's the descending bowel, again, the hepatic flexure, splenic flexure, transverse colon, the hepatic flexure, and that's the ascending bowel right there. And I think immediately you can appreciate just how narrow this bowel is. There's a significant degree of stenosis here in this bowel. And that's because of the scarring. The scarring causes the bowel to become very narrow, very stenotic. I think you can also appreciate that there's very little slack in this bowel. And over here you got a lot of kind of slack. The bowel's kind of hanging down here, a lot of extra length. This bowel goes straight up, practically straight across, straight down, because there's no slack in it. And that's again because of the scarring taking up all the slack. Scar tissue is causing contraction. It's responsible for the stenotic lumen. It's responsible for the bowel kind of contracting, taking up all that extra slack. But you'll also notice the luminal topography of this bowel is abnormal also. Okay? You see these filling defects in here. You don't see them over here in the normal bowel. These filling defects you see, those are pseudopolyps. Those are the pseudopolyps. And they're flanked on either side by areas of the bowel that are ulcerated. And so there's areas of the bowel that are filling up with contrast agent. Let's pool of contrast agent collecting in the ulcers. And they're surrounding the intact valve. You can see the pseudopolyps.
When you talk about the slack of the gown, is that like the elasticity or the?
Not so much the elasticity, but the redundant length that you have. So let's say, the valve has a lot of slack in it like this. Take out the slack, it looks like this.
Or more rigid?
Exit, well, not more rigid, it just doesn't have any, extra length to it.
Oh, I see.
Well, this would be slacked, this is under tension. Okay, so let's talk a little bit about the presentation. Okay, so again, this is a systemic disease, just keep that in mind. Colitis is the principal presentation. However, there's gonna be extraintestinal symptoms, arthritides, rashes, problems with the eyes. Okay, usually this develops in younger people, that's the first onset, but they'll have it for years. Presentation, chronic relapsing remitting diarrhea. Again, bloody diarrhea, they'll have cramps. They might have a fever during these episodes, don't count on it, depends on just how extensive the bowel's affected. Again, the disease has a cyclic nature. People can go for months without having a relapse, then they'll have another relapse. Sometimes a relapse, again, is triggered by another disease. Sometimes it's triggered by a specific food. The workup would include ruling out some other causes of diarrhea. But once you get that chronic relapsing remitting history, a clinician is probably going to be suspicious. They'll do a sigmoidoscopy. Again, you should see inflammation beginning in the rectum, extending proximally and contiguously. Again, no skip lesions. Probably see pseudopolyps because of the ulceration. The disease is not characterized by the formation of fistulas, and that's because the inflammation is not transmural in distribution. You'll see pseudopolyps, but you shouldn't see fistulas. That's not something characteristic of ulcerative colitis. Not that it couldn't happen, but it's not characteristic, really, classic ulcerative colitis. Okay, biopsy. Non-granulomatous inflammation, again, limited to the colon, specifically the mucosa and the submucosa. The inflammation should not extend into the muscularis propria. That is not a characteristic feature of ulcerative colitis. Not that it couldn't happen, but it's not a typical characteristic feature of ulcerative colitis. Okay. All right, typical ways we treat this condition. Remember, the condition is caused by an upregulation in physiologic inflammation. So, how would you treat it? Steroids. Steroids would be one of the first ways you'd want to try to treat it. Person doesn't necessarily have to be on steroids for the rest of their life, but you would put them on steroids perhaps to put an episode into remission. And they may periodically have to go on steroids. There are other treatments. You can interfere with inflammatory mediators like tumor necrosis factor. We actually have antibodies that are directed against tumor necrosis factor to interfere with its regulation of inflammation. That results in a reduction in relapses in these individuals. It seems that tumor necrosis factor is instrumental in causing these episodes, these relapses. Okay. Any questions about inflammatory bowel disease? Yeah.
What is the migratory polyarthritis? How is related to this? Is that
How
something?
is, I didn't hear all of that.
In your notes you have migratory polyarthritis.
Arthritis,
Polyarthritis, migratory polyarthritis?
yes.
Is that the same as UC?
That is an extraintestinal manifestation that's associated with these inflammatory bowel diseases, again, because these diseases, even though we're calling them inflammatory bowel diseases, they're not limited to bowel. They're systemic diseases, so, you can see, arthritis, again, skin rashes are very common. Retinitis is common.
So is migratory polyarthritis the most common presentation or secondary presentation?
Yeah, rashes and arthritis, degenerative changes to the joints, because the inflammation's again not limited just to the bowel. Anything else? All right, let's take a look at the next topic. We're gonna look at diverticulosis. What is a diverticulum? Diverticulum is described as a kind of blind-ending pouch somewhere in the bowel, extends out from the wall, leads nowhere. That's a diverticulum. It's just a little protrusion of the bowel wall, leads to nowhere, just a blinding pouch. Are you stretching or?
A little bit of both. I have a question. So, the Crohn's disease, sorry, I'm sorry, I'm going backwards a little bit, is the transmural non-necrotizing granulomatous inflammation. But UC is non-granulomatous, but it is necrotizing because of the polyps and the lack of slack.
I have to be carefully answering that, because there are two types of granulomatous inflammation,
Yeah.
necrotizing and non-necrotizing. It doesn't necessarily refer to the necrosis and destruction it causes, but rather what is at the center of a granuloma.
Okay.
If there's necrosis at the center of a granuloma, it's necrotizing.
Okay.
It's caseating necrosis. Other types of granulomas have no central area of necrosis.
Okay.
But all types of inflammation can cause damage and necrosis degeneration.
Gotcha.
Okay. Anything else on it? Al? Okay, so diverticulosis, we defined what a diverticulum is. It's a blind-ending pouch sticking out from the wall of the bowel. Numerous problems with diverticuli. Diverticuli can trap fecal material. Fecal material becomes stagnant. It can incite inflammation in the diverticulum. And when the diverticulum is inflamed, we call it diverticulitis. Diverticulitis can cause ulceration into the wall of the diverticulum, resulting in bleeding. Sometimes the diverticulum can perforate as a result of the inflammation, resulting in a septic peritonitis. Okay. We have two types of diverticuli. We've got congenital and acquired. Congenital, relatively rare. Usually the result of some sort of embryonic structure that didn't properly involute. And then we've got the acquired diverticuli. Relatively common, very common, especially over the age of 50. It's caused by a herniation through the bowel wall. Okay, let's talk about the congenital diverticuli. So these are the less common diverticuli. They usually are the result of some sort of embryonic structure that has not properly involuted. A couple important things about these congenital diverticuli. Usually they occur somewhere in the vicinity of the ileocecal junction. A common one is called a Meckel's diverticulum. It results from a failure of the infollomesenteric duct to involute. Gives rise to your umbilicus. Doesn't involute properly, it leaves this remnant that sticks out from the wall of the bowel. It's called a Meckel's diverticulum. The Meckel's diverticulum has a normal bowel wall architecture. There's a distinct mucosa, submucosa, and muscular expropriate. and the architecture of that diverticular wall is perfectly normal, resembles normal bowel wall. Let's take a look at a Meckel's diverticulum. Here's one. Again, occurring in the small bowel with, in the terminal ileum near the ileocecal junction. So we can see the ends of the terminal ileum here and here. The ends have been sealed off by staples. We can remove a segment of bowel. You can't just cut into it and let all the fecal material spill out into the peritoneal cavity. You actually have to seal it and then remove it. So these ends have been sealed by staples. You can see one of them right there. All right. There is the mesenteric quarter. This is the antemesenteric quarter. The bowel looks perfectly normal. It's got a kind of a grayish, whitish color, smooth, shiny, glistening surface. No inflammation here. This is perfect, this bowel. Except, you'll notice on the antemesenteric quarter, there is this bulge here. It's a blind-ending sac. That is a Meckel's diverticulum. Okay. Now, this Meckel's diverticulum can be complicated by a diverticulitis. That does not seem to be the case here. Actually, it doesn't look inflamed at all. It just looks like a diverticulum is sticking out there. The problem, however, is that fecal material coming through this bowel sometimes will aggregate here, form a fecalith, and stay there, and that will incite inflammation, and the inflammation eventually, the worst case scenario, can perforate the wall, and that's going to result in a septic peritonitis. Because of the potential complications of these Meckel diverticuli, if a surgeon is performing some abdominal surgery, something unrelated to the Meckel's diverticulum, if they see this Meckel's diverticulum, they'll resect this segment of bowel automatically. And that's probably what happened here, because there's absolutely nothing wrong with this bowel. It's not inflamed at all. It just has this Meckel's diverticulum, and so my guess is they're going in there for something else, and they just removed this segment of bowel when they saw Meckel's diverticulum. There are a few other complications that occur with the Meckel's diverticulum aside from trapping food and causing inflammation. Sometimes there's ectopic gastric mucosa in here. There's actually acid-producing mucosa in the Meckel's diverticulum. And that acid could damage the bowel, cause a lot of right-sided pain in the right lower quadrant, and it often masquerades as what? Appendicitis. So sometimes an inflamed Meckel's diverticulum can masquerade as an appendicitis. Okay. Any questions about a congenital diverticulum? So things to remember. Normal bowel wall architecture results from an embryonic structure that does not involve. Okay, then let's take a look at the more common form of diverticulum. Are we gonna have time?
We can start.
You got any questions? We need to waste 4 minutes.
Can you just repeat what you were saying about